So for those of you who are just joining, that was Craig Merrill. He's VP of Sales for Transcend Biologics, which sells a PRP product. I'm Dr. Frank Johnson. I'm up here in Calgary. Mike, can you introduce yourself?
Yeah, so Mike Galbraith, I actually used to know Frank up there in the Great White North of Canada. I practiced sports medicine up there for 11 years. I did my fellowship at University of Notre Dame, so go Irish for the college championship. Very excited. Finished my fellowship in 2010, and after 11 years in Canada, I came down here to sunny, warm East Texas. So I've been in East Texas doing some academic medicine and back in private practice, and have enjoyed doing PRP and some injection videos with Frank.
Excellent. So the reason we're offering this call today is because Mike and I started this company teaching ultrasound-guided injections back in 2019. And we've run 57 courses now. And out of those, on those courses, if I had to add it up, it's probably about 700 doctors, nurse practitioners, mostly docs, that have taken our courses. And out of those, maybe 700, probably only 10% or 15% have added PRP to their practice. So we got, trying to brainstorm and trying to figure out what are the barriers to people adding PRP to their practice. And it, there's lots. Number one, confusion about or uncertainty about which kit is going to be most appropriate. What's the actual recipe of the medicine I should be putting in? And gosh, people tell me PRP is really, really painful. As opposed to like a simple cortisone injection or a hyaluronic acid injection. So, geez, I'm not sure I know how to navigate that. And man, it's been a long time since I drew blood and all these barriers. So we thought the best way to help out with that was start running live courses to help people address some of those things, do some role playing, what should the actual interaction with your patient be like, and how can you use ultrasound to then find a vein. So if somebody's struggling with phlebotomy, you can pop in, find the vein, get the blood draw, and get back on track. So what we did was we made an online PRP course, which runs through an absolute ton of stuff. So what is it? How does it work? And how do I make it? How do I attract patients? How do I counsel patients? And how do I charge patients? And then finally, the medical part, right? So there's some things you should do and some things you should not do with with PRP. So we call that the 10 PRP commandments. Today, we're going to focus mostly on the injection technique, but also sort of the aftercare. And we're going to focus on the top 10. So if you want to get started with this course, please don't do it right now. Do it after the call. But we've got, if you go to sportsmedus.com/free, down here you'll find a Learn PRP free version of our online course. Now, obviously, it doesn't contain everything that's in the paid version. It's about an hour of video content, whereas the paid course has something like 6 or 7 hours of content, with me sort of navigating you through the documents that you should have ready in your clinic for success. 25 injection demonstration videos where I'm in my clinic, and I'm doing a screen capture of the ultrasound machine. So you can see what you should be seeing on your screen when you're doing these PRP injections. It's also really nice to see the patient positioning. Where does the machine go? How do the patients tolerate it? For example, this injection for the AC joint, patient tolerated it quite well. CMC tolerated it quite well. The plantar fascia injections, man, nobody tolerates plantar fascia injections very well. So that's what's in the course. There's also a kit comparison, which I think is valuable because I think the Tropocells from Transcend product offers great flexibility at a great price. So I think it's worthwhile being honest with people and say, look, here's all the different kits you can get. Let me introduce you to the Transcend team and see if this fits into your practice. So we're going to scroll forward to just a quick reminder about what on earth PRP is. So this was a paper from Arthroscopy in 2019 and is a great, great, great picture. One of the best pictures I've ever seen for demonstrating what PRP is. So you take your whole blood and the platelets are interspersed, equally distributed among the white blood cells, red blood cells. There are kits that highly, highly concentrate all the platelets down here by the white blood cell layer. And there are kits that sort of separates the PRP well away from the red blood cell and white blood cell layer. So the beauty of the Transcend product is it's super duper easy from a blood draw standpoint. So it's a 22 mil product with a gel separator. And so you drop in your 22 mils of blood. There's an anticoagulant in there, and you spin it. It can spin fast. It can spin predictably, and then you draw off what you don't want. So, for example, the top of this is going to be not very rich in platelets. So what you'll do is you'll get rid of that part and discard it. And then let's say you only need 2 milliliters of PRP for, let's say, a common extensor tendon. Well, you would take the final 2 milliliters of the highly concentrated product down here. Let's say you wanted to do two tennis elbows, 2 patellar tendons, and an intra-articular knee joint. Well, Transcend sells a kit with, not 1, not 2, not 3, but up to 4 different vials in the same package. Now, again, to be clear, you can buy the 22 or a 40, you can buy an 11, a 22, a 44, a 66, or an 88. So there's lots of flexibility. In the course, you'll get to see Michael O'Brien. He's the CEO of the company, talking about what he thinks are the real advantages of this product. There's a couple big advantages, and I go through it in the course, but I think they managed to crack the nut of what's the best way to use a vacuum tube gel separator system. So I do like this product quite a lot. But then I go through and again, honestly review some of the pros and cons of the other products, because whatever PRP product you get, we want you to be happy and feel supported. And I think the Transcend team is really good at supporting people through the process. Mike, when you got started, you started with a gel separator system. Is that right?
Correct. Yep.
Have you stuck with the gel separator system? Have you added something else to your clinic?
Well, I would say in full transparency, like I started way back in the day with Harvest and Magellan were the two that I used in my training. And then when I was up in Canada, Smith and Nephews had a PRP kit that I used. And then I've been most familiar with the Arthrex ACP system over the last few years.
And the Arthrex ACP system is a good system. It'll get you 1.2, 1.5 times concentration quite reliably. And the beauty of the Transcend product is that it can, using their system, using their sort of recipe that we'll teach at our course in Dallas when we do it on January 8th to 9th, is how we can get up to and Craig can chime in here if he can hear me. I think we can get up to like a 5 or 6 times concentration. You've got some independent data to demonstrate that. Is that correct, Craig?
Yeah, that's correct.
Craig.
On the 22 ml, we can get up to 5-6 times. On 44, definitely.
Excellent. So
I was gonna say, I think that's one of the great benefits and the beauties of this product is the ability to get that higher platelet concentration, because I think there is something to be said about that volume and concentration.
Excellent. Now I have advanced I've got a little monitor over here. I've advanced my slides a little bit, and Mike, are you seeing a jump here screen?
Yes, sir.
Okay. Yep. I'm going to stop sharing and try. I don't know if I've got a funny internet connection at the moment, but I'm going to hit stop sharing. Let's start with supraspinatus tendon, because that's the most, apart from common extensor tendon, I think supraspinatus tendon is by far my most common injection. So supraspinatus tendon, I think choosing the patient is the most difficult thing, because I'll get referrals from clinics that say, I've got my patient with a very high grade rotator cuff tear with retraction. I don't think that's an optimal candidate. What are your thoughts?
I agree 100%. Yeah. And I love that you talk about appropriate patient selection. And I think that goes for everything, including PRP. And I think if we really want to put patients up to really succeed, I think we need to really educate them and help them identify, hey, here's why I think you would be a good candidate, or here's maybe why I don't think you would be a great candidate for PRP.
So I've been to so many PRP training sessions, so many lectures, and nobody ever gave me a recipe book. Nobody ever gave me a list of what should the timing be for PRP, what's an optimal candidate, what's a suboptimal candidate. should I be using anesthetic? And if so, how much? How much PRP should I put in my syringe, and how much should I inject? So as I was going through the development of this online course, I thought, this isn't rocket science. Why has no one done this before? Why don't I just do this? And so by going back and forth with Mike and a few other contributors, we came up with what I think is the most comprehensive recipe book on the market. So, for example, supraspinatus tendon, I think that it is, I really want to have sort of 5 mils of PRP to get started. And maybe I won't use it all. I probably won't use it all, but I really want to have it all. I will frequently not use anesthetic into the tendon. The first reason is high-dose lidocaine or bupivacaine will decrease the functionality of the platelets. That's the first thing. Second thing is there's a concept in tendon treatment from physiotherapists, and the concept was that you want to treat the donut, not the hole. So what that means is, let's say you have an Achilles tendon and the central part of the Achilles tendon has a tear. Well, if you take a needle and poke into the center of the tendon, that area where the tear is may be completely insensate or asymptomatic. But you poke around the edges of the tear and the patient may freak out and go, holy cow, that's the area where my pain is, meaning the area that has not yet been torn is actually the most painful. So when you use anesthetic into a tendon, you eliminate that ability to get feedback from the patient. So I like to do these injections. I like start these injections without any anesthetic if the patient can tolerate it. If the patient's not tolerating it well, yes, I will use a small amount of dilute anesthetic. So what I do is I take a normal saline syringe. I usually get that, well, for supraspinatus, I probably get a 3 mil one. So I do have to update the recipe book in a couple places here, but I'll take a 3 mil syringe. I'll push out maybe half mil of the saline, and I'll pull up 1% lidocaine. So now I've got a half part of lidocaine diluted by about 2.5 of normal saline, and I'll push in just 0.1, maybe 0.2 into the tendon. And as I'm passing my needle, about to put in the anesthetic, I say, "Is this where your pain is? Is this where your pain is? Is this where your pain is?" And often it's the adjacent infraspinatus tendon, or again, the tissue immediately next to the tear that's actually the most tender when you're poking with a needle. And of course, don't forget the long head of biceps. So when I inject, for a supraspinatus tendon, about 3 milliliters is a common amount. I then finish up with a patient, and then I say, here is your prescription for some Tramoset. And they go, why would I need that? And I say, well, it was sore when I was doing it, and tonight it's going to be even more sore. Mike, do you have a go-to analgesic for post-procedure first night?
Yeah, so depending, I think for tendon, like most joints aren't bad, but right, as we're talking supraspinatus, I usually recommend extra strength Tylenol, and then I will use like a tramadol or a codeine or a hydrocodone for the first 48 hours if they need to for tendons.
Can you think of the most painful reaction you've had in a patient for supraspinatus? I've got a couple that stick out in my mind for other body parts, but I don't have any specific memory about a bad.
Yeah, I don't know. Sometimes you can pinpoint, it's like, okay, here's the reason why. They did this, or maybe my tenotomy was way too aggressive, right? But I think if most people, if you really educate them beforehand, and then they jump on board with analgesics immediately afterwards. And I try to have them for the first 24 to 48 hours take either extra strength Tylenol, and then if they need something stronger, they have it on hand. But for those first usually 48 hours or 2 days, usually it's tolerable. But I think some people, they're like, I'm just going to tough it out. I'm fine. And then, then it's tough as you're chasing the pain, and they wake up at 2 a.m. and they're cursing your name and wishing they had your cell number.
So now we get to, is there a way we can reduce the pain without drugs? And one of the ways we can reduce pain without drugs is to put people in some sort of immobilization. Most docs that I talk to, certainly the docs that I help me host the webinars who've got a lot of experience, they say, I started out doing more immobilization when I was newer and I was a bit more uncertain. But as I've accumulated dozens and dozens of cases, I've gotten away from putting people in a sling for 2 or 3 days. Like, I don't actually remember the last time I put anybody in a sling after rotator cuff PRP. Do you?
Yeah, I'd say it's really uncommon. And it's funny, I was just nodding. It's like, wow, I remember I used to put everyone in a sling because I think a little bit of the fear of the unknown, right? You don't have as much experience. And as you get more and more of these reps under your belt, you have a better idea of kind of what to anticipate post-procedure wise. So it's rare for me to put someone in a sling. For me, I think if you just get kind of that spidey sense, this patient just, I don't know, their pain just always seems to be out of proportion every time they come in. Maybe that's someone I would put in a sling for a couple of days. But generally speaking, I just tee up people, they just modify their activities, and that's usually sufficient.
I'm with you. Now, one of the other questions I get asked frequently, so I did a supraspinatus PRP for a lady today. The reason we did it for this one patient is because she had a menstrual bleed, like a uterine bleed. It wasn't a true menstrual bleed; it was more of a uterine bleed because she was postmenopausal. She had a uterine bleed after 2 doses of triamcinolone. So this was for an unrelated medical condition. It was essentially a back pain, and on day 1, a random day in the summer, she had facet joint injections totaling 40 milligrams of triamcinolone. 7 days later, she had the contralateral side injected, once again 40 milligrams triamcinolone. 2 days after that, she had a menstrual bleed that lasted, she had a uterine bleed that lasted, is intermittent. It wasn't a gusher, but it went on for a couple of days. So that sort of spooked her. She's like, I don't want to know if I want to do cortisone anymore. So we switched to PRP. And she's tolerated the PRP quite well. She hasn't needed a sling, but so her question to me was, I was under the impression that the PRP will build some sort of scaffold to fill in the tissue that's been torn. How do you handle that? So I don't think that's true because I've seen it happen. I see where the fluid goes, and it just doesn't happen. How do you handle that conversation with patients? Like, will this injection heal my tissue? Will it grow new tissue?
Man, those are hard too, because I think, honestly, when you have those patients that seem pretty educated, they've been doing their research on PRP, they've been studying Google, some of them are coming to you for second opinions. Sometimes it's hard to change some of those preconceived notions. I think over time, we have learned that we don't have great evidence that PRP consistently regenerates tendons, right? Can it? I think there is potential, but does it consistently do that? I don't know. And so I agree with that sentiment. So what I usually tell people right up front is, I don't know if this is going to regenerate your tendon. I don't think we have great research that shows that, but we do have pretty good research that it's going to help with your pain. And so the goal is, let's reduce your pain and let's improve your function. It's going to take some time, but I think we can help you. Whether or not it regenerates your tendon, I don't know.
So here's a picture that we include in the online course. And this over here on the left-hand side is a normal, healthy supraspinatus tendon. So the features of a normal, healthy supraspinatus tendon are the space between the acromion and the humerus is the same as a non-injured part of the tendon. So for example, we look at the space where the infraspinatus is, and let's say that measures 6 millimeters, and we come around to the supraspinatus. If it's the same, you're like, okay, well, there's no reduction in size. The second thing is that where the supraspinatus tendon attaches to this aspect of the humerus, this is a beautiful smooth edge. Now we get over to here, and this is an example where there is what we would call a cortical irregularity. Now, most frequently we will see a dip. However, in this space, I think this is sort of a dystrophic calcification from a long-standing tear. Now, my needle's inside the tendon. And Mike, you did say something about if a patient is really, really bad that night, one of the possibilities, or one of the questions is, was I a bit too aggressive with my tenotomy? So for those of you who haven't done this specific treatment before, what we'll usually do is pass the needle back and forth several times. What's the purpose of that, Mike?
Yeah, and I tend to do that tenotomy more in someone that has tendinosis versus, let's say, a large tear. or a tear. If I do see tearing, I try not to do too much of a tenotomy, or maybe I do it in some of the tendinopathy adjacent to it. Well, we have some research from years ago that even just tenotomy can help with chronic tendinosis. And so then there's some theory that maybe that adjunct tenotomy with the PRP can maybe help, or the tenotomy can maybe augment the PRP in someone that has that chronic tendinopathy. But I'm a little cautious. I just try not, I used to use a bigger gauge needle and be more aggressive. Now I've kind of backed off to a slightly small, like I literally used to use like an 18 gauge needle tenotomy plus PRP. And I was like, all right, that's pretty aggressive, right? And then in a little bit of a prolo approach, I think I'd be a little too aggressive on the bone too. And so you learn some of those things, and unfortunately you flare up some patients, and they teach you lots.
They teach you lots.
Yeah.
Now, if anybody has any questions about this specifically, again, we're dealing with supraspinatus time right now. We're going to go through some of the top 10 tonight. Any questions, feel free to pop it in the chat. Now, the next question is something that's come up a couple of times in a couple webinars is, do we have to worry about getting the PRP into the bursa? So my personal opinion on this is our job as a healthcare provider is to put the needle into where the tear is, the area adjacent where the tear is, try to find out where the area that is most painful is, because that's the area, that's really the area we want to treat. And as we inject a little bit, so essentially the tear is this defect here that I'm marking out. And as we injected this one tendon, it was obvious that this was completely detached, all this. And so as I'm injecting small aliquots of the PRP into here, it was obvious that the PRP was bouncing off the healthy tissue, washing over the torn tissue, and settling into the subdeltoid bursa around the corner. And that was like literally 0.1, 0.2 mils. So, and the more I added, the more it bounced off and landed around the corner. So I think it's almost inevitable that when you do a PRP into a rotator cuff tear, you're going to get some fluid into the bursa. And that's not something I consider a risk factor for a profound inflammatory response. It's just where it goes. Have you got a different thought process on that, Mike?
Yeah, no, I think it's a great comment. And I might even go back and add to a comment you made earlier. You'd made comment, is you're examining the patient, where's their point of tenderness, even the infraspinatus. And I think we love ultrasound and it's really important, but just a reminder, hopefully as physicians, we're doing a really good exam. And we really have to correlate what we see on exam with what we see with their history, and then also with their ultrasound. And so don't be afraid, you will have healthy tissue that looks completely normal on ultrasound, but man, they're either they have pain or weakness with functional testing, and that may or may not include palpation. So I think it's great to treat some of these areas that have pathology, but also there's going to be some surrounding structures that may benefit from PRP too, even if it looks normal.
So getting to that very thing, so Riz is up at, if this is the Riz I'm thinking about, he's up in Toronto, he's been doing PRP for an awful long time. And his question was, if I see this sort of, tear, would I add in some to the glenohumeral joint? And I am probably not in the habit of doing that, but I think that's a great idea. If on your clinical exam, there appears to be some glenohumeral joint pain. However, I also know that the more PRP I start throwing around, I may not get any additional benefit, and I might get additional post-injection aggravation. So if you think their rotator cuff tear, if their rotator cuff tear was a traumatic one from a fall, and the fall, subluxated the humerus inside the glenoid, you might have a slap tear, you might have long-headed biceps pain, then absolutely in that scenario, I think it's probably a great idea to add some into the glenohumeral joint. If it just seems like it's a degenerative tear in somebody who's never really had shoulder trauma, and they said, I literally just reached in the back seat to get my jacket and I pulled and something snapped. I think that's a case where you can say, let me just focus on the rotator cuff and leave the joint alone. So I'll hit play on this, and we're going to leave the audio muted. And what we see here is essentially my PRP needle. It's a 27 gauge 1.5. And watch the technique of using the plunger with my hand. So this is my way of pushing in small little aliquots of PRP and seeing what the tissue integrity is. Sometimes the tissue integrity is really, really robust, and it's like trying to inject into a something that is really resistant. And other times it just flaps open like a massive tear. And I'm really glad I had that 5 mils, because the first 2 mils just disappeared somewhere, and I've still got lots of painful areas to treat. Mike, what's the most you think that a supraspinatus should tear? Like in the cheat sheet earlier there, we said sort of, 3 for the tendon, maybe upper limit of 6. Would you agree?
Yeah, I would say I've tended to use a little bit lower volume. I might use total volume. If I can get 4 or 5, I may target 2 to 3 in that tendon into the tear, and then I start doing again some of the adjacent tissues that I think are really part of the pain generators.
Got it. Well, that's supraspinatus tendon. Any questions? Pop them in the the chat. Now, what I showed you previously was simply the PRP and the cortisone algorithm. The full HA and Prolo algorithms are in the paid course. So let's have a look at the glenohumeral joint. I see an awful lot of people in their 40s where I'm the first one telling them that they've got some glenohumeral joint arthritis. That's usually a scenario where I've got someone who comes and they say, I've got anterior pain, lateral pain, and posterior pain. But the referral from the physician or the therapist says, it's probably a bursitis, and I think the clinical reasoning is that patients only in their 40s, why on earth would they have symptomatic osteoarthritis? I've picked up this little tip. When I look at the posterior glenohumeral joint, if I see any irregularity on the glenoid, I'm immediately saying in my mind, I think this is degenerative changes that are much greater, that are represented on ultrasound scan or on radiograph. So I'm ordering MRI to then help my patients understand what the extent of the degenerative change in their glenohumeral joint is. And quite frequently, they've got bony edema in both the glenoid and the adjacent humeral head. So that's my first little pearl is now, don't blurt it out if you don't have any evidence or you don't have a ton of experience. I think that would be a mistake. But you need to be skeptical. You need to think, hey, people in their 40s will have degenerative changes. So in a degenerative joint, in somebody in their 40s, I usually lean to cortisone first. I'll then usually think about a bit of hyaluronic acid, and PRP is usually my third option. Do you have a preferred sort of algorithm? Because I'm in Canada, I can put HA in any joint and it's covered by insurance, but I know it's different for you down in Texas, isn't it, Mike?
Yeah, so I would say traditionally over the number of years, that's been exactly my go-to. I'm a little reluctant, right? If you have someone, you try not to put too much cortisone into their soft tissue or joints, but I think it's reasonable to say, hey, I'm going to try this once and see how you respond. If they're just not responding, I just don't love the idea of doing lots of repeat cortisone, which I know you agree with. I did a lot of HA into the glenohumeral joint when I was in Canada. Here in the States, hyaluronic acid is only FDA approved for the knee. And so if someone's paying cash, it depends where. Our clinic, the private practice I'm at right now, actually sells Durolane for $400, which is considered very low. And then many places, like for PRP, it depends what they mark that up. So generally where I'm at now, if they're not getting better with cortisone and some good physical therapy and rehab, then I usually offer that option of PRP. And I'll comment on HA, but most patients, when they see the price difference between HA and PRP isn't too much, they're like, I'm just going to do the PRP.
I'm with you. Now, the patients that most frequently come to my office asking about PRP are patients with advanced disease, high-grade rotator cuff tears, advanced glenohumeral arthritis, advanced hip arthritis, advanced knee arthritis. These are the tough patients to treat no matter what, right? So I think reputation preservation and your reputation management is very important. So I will absolutely do PRP treatments for somebody with quite advanced joint disease. However, I want to make it very clear that I think the evidence doesn't support the fact that this is the best possible treatment. The best time to treat this would have been 5 or 10 years ago, but don't worry, all's not lost. We can still do some treatments. So that's why I put in here, I think, a suboptimal candidate. When I see people's knees will swell at the drop of a hat. You get a tiny little meniscus tweak, boom, it swells. Little MCL injury, boom, it swells. Like, I only see glenohumeral joint effusions in people with significantly advanced glenohumeral joint osteoarthritis. Would you agree that glenohumeral effusions are a sign that, hey, this, like the canary in the coal mine, hey, this is bad?
Yeah, you don't see a lot of them, but I agree. I typically only see those in someone that has severe glenohumeral joint OA. And then you think, oh man, I mean, we're happy to do it. We can try, but I'm late. I can't talk. I'm less optimistic that they're going to have great outcomes compared to that person that has maybe mild or early degenerative changes.
5 years ago, I was, so I've been a sports med, so I've been practicing 14 years, and I've been, only doing sports medicine for about 6. So one of our early courses, Mike, we had a chiropractor attend, and we were chatting, and I said, I'm just not comfortable telling people they need to stop their tennis. They need to stop their arm wrestling. They need to stop shoveling. My buddy, who's an experienced chiropractor, he said, look, you need to help guide people. That's part of your role. And if you're not comfortable with that, that's okay. But you'll need to develop more comfort with telling people what not to do. So I can think, if I was going to do glenohumeral joint PRP in somebody with advanced disease, I would say, I need you to stop trying to get greater range of motion, because it's not going to happen, and you're going to be aggravating this joint. I really need you to stop shoveling snow aggressively and maybe create a job for the neighbor kid down the street. How are you at your coaching for shoulder issues? You need to stop doing this. You need to stop doing this. Otherwise, we're going to get nowhere.
I think there is something to be said about having some relative rest and giving them some activity modifications. It sounds mean, but you almost have to sell it. Like, if you really want to get the best outcomes, you're going through this, you're paying for it. Your best chance of having the best outcomes is if you just let it try to heal, give it some recovery, do some physiotherapy or physical therapy within reason, instead of just trying to push through it, right? Yeah, so I agree 100%.
So this is the type of this is a normal glenohumeral joint. So top left on the screen, and this is the way this is how our educational products work, where you're normally like a 4-frame view. This is the ultrasound probe hovering over a cast model of a skeletal humeral head adjacent a skeletal glenoid. So then the corresponding ultrasound image that would be generated would be this round thing over here, which is the humeral head, and then this sort of a triangular thing, which is the glenoid. Normal appearing glenoid, as we were talking about, would be nice and curved like this. As soon as I see sort of a sharp edge, that's when I'm thinking, this is more advanced degenerative changes than anybody knows about, so let's get an MRI and have a peek. And if I see fluid in here, now this is fluid I put in, this was a hydrodilatation, but it demonstrates the point. If you scan a posterior glenohumeral joint and you see this, well, they either injured it recently or this is a bad joint. Now, the beauty of having that effusion is it's easy to get the fluid in. It's easy to get your needle in the right spot. Now, this is a gentleman, this is a hyaluronic acid injection. I've got, since I made this video and put it in this course, I've screen captured another, I've shot more videos with 2 more glenohumeral joint PRPs, so I'll get this uploaded in the course. But whether you're doing cortisone or hyaluronic acid, or you're doing PRP, the technique is the same. I like using for larger, like for guys with a larger, more muscular shoulder. Now you can see his glenoid is down here at 4 centimeters. When I've got a larger shoulder, I like to use the curved probe. When I've got a smaller shoulder where the glenoid might be up here at 2.5 or 2 centimeters, I'll use a linear probe. Now, Mike, you were using a sort of a handheld ultrasound for many, 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 many years with satisfaction. What, why did you decide to sell the handheld and move to a larger system?
Well, just there's been some amazing updates in image quality and ultrasounds nowadays. And so, I mean, with price points nowadays too, you can just get some great machines that have better images, and then also have the ability to have both the curved probe and the linear probe. And everyone will have their own preference. I did a lot of linear hips in Canada with just that one single linear probe down to 6 centimeters, and that was kind of where I had kind of tap out. And so, but I prefer to have a curved probe with deeper structures. For me, I usually will do linear to about 4 centimeters for glenohumeral, and then beyond 4, then I usually switch to a curved probe.
Okay. I like that. So again, what we're doing here is you can see in this gentleman, now I'm a little bit more distal, and he's got his arm in an adducted position with some flexion of the humerus. And so this isn't exactly the same slice where we would see the round humeral head. But again, we just got a beautiful spot where I can just slip that needle right up against the humeral head and inject. All right, moving on to common extensor tendon. Holy cow, this is real bread and butter. And unless you're celiac, it would be lettuce and dressing.
We need a better analogy.
Yeah, so the common extensor tendon. Okay, let me tell you. Oh, remember we were talking about? Do you have any memories of patients that did described horrific pain? So I got this one guy who's a beloved patient of mine. I love the guy to death. I've treated him for years. And he played a collision sport professionally in 3 or 4 different countries for almost a decade. And he came to me with common extensor tendon pain that had been going on for a while. He had a small little tear in his radiocollateral ligament, mostly tendinosis. And I did PRP into his common extensor tendon. He came back to see me a month later. He said, that was the most painful thing I've ever experienced in my life. And I'm like, you've broken bones. You've been at the bottom of pileups. You've had people scrape their boot in your face. Are you kidding me? And he said, I'm not kidding at all. It was intense. But I woke up the next morning and my pain was gone. And I said, that is not, you're pulling my leg. And he said, I swear, I'm not kidding. And I know this guy to this day, and his pain's never come back for that common extensor tendon. So I think that's an extreme outlier.
I think you scared him.
I tell that story to patients, not to scare them, but to prepare them that this could be bad. So here's your prescription for Tramoset. I want you to ice when you get home. If you feel the pain start to do a bit of a runaway, here's a Tramoset. I want you to do some icing, and we would brace you. And in that case, I want you to get a brace from the drugstore. Now, the brace you would use would not be an elbow brace. I suppose you could use a sling, but you really want to eliminate the tension on that tendon. So you would do a wrist brace. Do you remember last time you put somebody in a wrist brace for tennis elbow PRP, Mike?
I would say it's silly. I actually probably am starting to do that more and more. As I've weaned away from the sling from the shoulder, I would say I'm starting to use like that carpal tunnel splint or that volar wrist splint a little more for people afterwards. And as I was just hearing you tell that story made me think, I think there's one thing that we've forgotten on this recipe is like follow-up. When should you have the patient follow up in the clinic, right? When do you follow up with them? Like, is it the next day? Is it a week? Is it a month? Yeah, that's something we could consider too, because I've had a lot of people ask questions on that, and it's really variable.
Yeah, that is great. This recipe book's going to wind up being long, but it's a great point. So what's your approach usually? Do you do a phone call in a couple of days to check in? Do you bring them back in office? What do you do?
Yeah, I kind of joke with them after the procedure, say, hey, I'm going to call you tomorrow just to make sure your arm didn't fall off. I want to see how your pain's doing, make sure we're managing it okay. Then I usually have them check back in about a week. That's usually for tendons, because again, most joints, if you're doing like a glenohumeral joint, a knee joint, they're usually not that painful. It's usually the soft tissue that I worry more about, that supraspinatus where you're doing tenotomy, or that extensor tendon where there's tenotomy. So I tend to call them about the day after, and then I usually have them follow up about a week later in clinic.
I like that. And then when it comes time to say, when do we do it again? Usually, this is almost always my go-to. We'll make a decision around the 4 to 6 week mark, and then we'll repeat it a couple of weeks after that. And I don't think there's a ton of great evidence for, and even if you find 1 or 2 good papers that say this is a good protocol, you'll find other papers that say, I don't know if that's true. So I think you just have to find something. There's some docs that sell packages. Did you ever look at selling like a package of 2 or 3?
You know, I didn't. I have a very, I'm very upfront with patients right at the beginning, and I have that same conversation. I like to reevaluate around this 4 to 6 week point. Do we do it again? And let's kind of see where we're at. And I say some patients, they benefit from that second injection. Others say, hey, I'm doing great with 1. Let's just watch. And I think that's totally reasonable. But I've never really offered that package.
I'm with you. So here's our example where our lateral epicondyle is over here, our radial head is over here. This is a normal appearing common extensor tendon, and this one looks like a dog's breakfast. So the deep aspect is actually the ligament. So if you ever get an ultrasound report or an MRI report and they say the deep aspect of the common extensor tendon, anatomically speaking, that's about here, and everything below that is radial-collateral ligament. So this is an example where I would pass my needle here several times, putting in a small aliquot here, 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 here. Once you put your needle here, it's quite likely that whatever you put here is simply going to escape into the joint. So just make sure that you don't inadvertently slam in an awful lot of PRP into the joint if that wasn't your treatment plan. Okay, there's a question there from Riz. Would you do fenestration and barbotage with PRP for calcific tendonitis or just PRP? So Riz, if you can clarify for me, are you talking elbow or shoulder? Because I treat them a little differently. So now this is an example where I use a red PRP product. We doctors, we say things like there's no evidence for, or the best evidence says. And in reality, what we're trying to do is we're trying to justify, I think we're trying to justify our current practice or justify a change in practice. I think you can find evidence to support using a red leukocyte-rich PRP. I think you can also find evidence to support using a very dilute PRP. You can find evidence to literally say, take the blood from the vein, pull it out, and literally inject it back in the tendon. There's 4 or 5 papers we could find in a few minutes to say that that is also a helpful thing to do. So in this person, what I did was I used a leukocyte-rich PRP. It's a 3 ml syringe. I've got a 27 gauge, 0.5 inch needle. 27 gauge, 0.75 inch needle. And so what do we see on the screen? We see the tissue separate like that a bit as I'm injecting it. And that's, you know, in this specific case, you can kind of see a tear open up. Now, we would call this an interstitial tear. We call this a delaminating tear. Gosh, I learned the hard way. Don't say that in front of patients. They get scared. But really, it's just an area where the tendon integrity is such that these things, these things are no longer Velcroed together. They just open up. And as I inject this fluid there, if I inject much more, it will simply shoot from screen right to screen left distally by 10 centimeters. So you can make the mistake of pushing in a lot of fluid here, and it winds up creating a bunch of pain down here because that's where it's settled.
Well, I think that's a good point too, Frank. You know, when you talk about what's the ideal volume in an area, I think we're really learning and our comfort level changes, but I used to push harder and I used to push faster. And now I agree with you. I do test doses and I see what I can tolerate. And I find I probably need a little less volume than I did years ago when I would just kind of just blow it all in there.
I like that. Okay, Riz clarified. I'd like to know thoughts on both shoulder and elbow. So Riz, specifically when it comes to calcific tendonitis in the shoulder, I usually tend to stay away from PRP. And I don't have a great reason. I'd love to hear Mike's reason, and Riz, if you have your strong opinion, I'd like to, and maybe throw it out to the whole group. Does anybody have a strong opinion about shoulder calcific? So stable but painful shoulder calcific tendinopathy. What I mean by stable is the calcium is not currently actively in a state of breaking down and being reabsorbed. We're talking like a stable stone it was there a year ago, it's still there a year. You poke it with a needle, and it's just like it's like knocking on a door. I stay away from PRP. I don't do PRP in those. Mike?
I would say I have not done PRP in those very often. I find that calcium, I think you bring a good point. Sometimes I find the calcium is really mature and it's hard as a rock. The chances of you really being able to break up that calcium, especially, and then try to absorb it and aspirate it, you're I think just kidding yourself. And now if it has the consistency of toothpaste, that's maybe a different story, and I think you might have more success. I tend to use local anesthetic, and I'll use an 18 gauge tenotomy really to try to break up that soft calcium toothpaste, and then I'll try to aspirate it as much as I can. I usually will put a touch of cortisone in the subacromial bursa after that. I have, in someone that's done the cortisone route or intolerant to cortisone, I have done PRP, but to be honest, it's not common that I do that.
And for elbow, I mean, calcific tendinopathy in the elbow is, I'd say, probably less common than well, I don't know. Let me take that back. I don't know if it's less common or not. I genuinely don't have any prevalent stats on that. What I would say is when I scan people with lateral elbow pain, I very, very rarely see calcium in the lateral elbow. I relatively commonly see it in the shoulder.
I will say, like with the elbow too, you'll see that spur really frequently, that real spur off that lateral epicondyle. And some people try to chip it off with a big needle. I don't. I just do a little bit of a tenotomy near that spur and then do my injection. I don't try to chip it off with an 18 gauge.
Yep. And we've got we've got at least one surgeon on the call, at least I thought. So, and any surgeons have any thoughts about trying to chip off bits of bone with a needle? I'd love to hear them. Okay. Let's move on. It's good conversation. I don't know if we're going to get through all top 10, but we're certainly going to do our best. First CMC joint. Almost every CMC joint I see is quite arthritic. Here's an example of a relatively younger man. So this is a 40-year-old with really quite a large osteophyte on the metacarpal and quite a large osteophyte on the trapezium. We can see here in this WeSonic Navi scan. There's the WeSonic Navi. We'll have those at the PRP course in Dallas coming up here in February, and we can see sort of an expansion of the joint capsule with this gray tissue. The explanation here is that this is an active synovitis of the joint. Now, what I did in this case was I just took 0.5 mils of PRP. The reason we did it was because this gentleman, he's had maybe 20 cortisones over the course of sort of 5 years. And we just had to try something else. And his answer for me was, he said the PRP was significantly more painful in the 3 to 5 days afterwards, but I feel like it lasted about twice as long as cortisone. And I've used that, and some other patients have told me that as well. Now, all full disclosure, I've had patients say the opposite. They say, the cortisone lasted 2 to 3 times longer than the PRP. Have you done many advanced CMC osteoarthritis PRPs, Mike?
Yeah, I was going to say advanced. I haven't done as many advanced. I've done a lot of mild to moderate. And I found, how much lidocaine do you use beforehand? I'm just curious.
In this, 0.
0?
You?
Yeah, I found if I can do about maybe even 0.5 mLs, just sub-Q and then down to the capsule, and then I give it 20 seconds, and then I do my PRP, I find it's tolerated a little better, because I do find, and I don't know if it's just because there's that active synovitis, it's really inflamed, it's really irritable, it's more likely to flare them up. But sometimes PRP really can irritate that base of the thumb joint.
So if I heard you say right, you'll take a small amount of lidocaine, do the skin, do the muscles, and down to the capsule. Would you penetrate through the capsule and drop any in here or no?
I try to keep it just into the capsule. I try to keep lidocaine out of the joint if I can. And that's kind of a general principle that with whatever joint. I try to do that periarticular capsule as much as I can. There's so many nociceptors there, pain fibers, but I try to keep the lidocaine out of the joint if possible.
I'm with you. Hip joint. One final CMC pearl there is most people with advanced CMC osteoarthritis will have a defect in the capsule. That's my personal experience by injecting cortisone and hyaluronic acid and PRP. And so therefore, I think don't try to be a hero and slam in 1.5 or 2 mils. Most of them will have a leak and it's just going to go somewhere else.
And then the really
hip joint, I always feel like knee responds better than hip. As long as I keep that in my mind, then I'm always pleasantly surprised when a hip PRP responds really, really nicely. In fact, I've had 3 in the past month that responded really, really nicely. But my little pessimistic brain kind of said, I don't know if it's going to work all that well. What's your experience with hip joint PRP, Mike?
I think I seem to see best results probably with knee more than any other joint. And maybe there's a little selection bias. I tend to do more knees than any other joint too. But yeah, I agree. I tend to see not quite as good outcomes with the hip.
Now, these 3 that did well were active males between the ages of sort of 45 and 60. I just can't remember a ton of females I've done recently, but these people came back and said, I'm a heck of a lot better. So it was like, they're like, great job. I'm like, hey, this is you, not me. I took your medicine and gave it back to you. I feel like you shouldn't even have to pay for this. Well, I didn't say that. Now this is a gentleman who is a lovely, lovely man, and he has asked me to do PRP on both hips for presumptive labral tears with mild degenerative changes, and I've injected each of his hips maybe 10 or 12 times, and I might get the same response with cortisone, but he says, I get 3 or 4 months out of it, and so therefore it's natural. I'm not putting in the cortisone where I might be worried about rapidly progressive hip joint disease or avascular necrosis, and so although we're only getting 3 or 4 months of benefit, he's satisfied, I'm satisfied, and we're not putting in a drug that sometimes hip joints don't like. Mike, can you remember any cases where you've done cortisone and had a rapidly progressive hip disease or an AVN?
Gratefully, I've only had, I think, one I can think of off the top of my head. But I think that's something you have to be really careful of. You can't ignore that. And I'm impressed. He's thin. His joints down.
Oh yeah, so we're talking about that linear probe there, eh? So this is an example where the femoral head's up at 3 centimeters, where in the gentleman earlier, his glenoid was down at 4. So just a nice example. Now I did use the curve. Now in this specific video, I recorded both the right and the left injections. The right was done with the linear probe, and the left was done with the curve probe. Simply, it was just a nice comparison video that I thought I'd shoot and put in the video in the course. GT bursa, I don't specifically inject GT bursa with PRP. I think it's rarely used for this body part, but what do? We go to the gluteus medius or gluteus minimus tendons, and I do this quite a lot. I think putting cortisone in and around these tendons can be helpful, and it's what a lot of patients will ask for. It's what a lot of practitioners will ask for. But when I inject cortisone into a 60 to 70-year-old woman's GT bursa right next to her tendons, twice, I'm starting to think, oh, if this tendon tears, we've got a problem, and it's not my problem, it's the patient's problem. And so I at least let them know I'm not super keen on doing this cortisone repeatedly. I'd really much rather switch to a PRP product. What's your sort of take on that, Mike?
Yeah, I mean, I agree 100%. Yeah, and I will extrapolate to generally most soft tissues, but it seems like how many times have people referred to you as like, hey, I've already had 4 cortisone injections of my bursa. Can you do one more? I'm like, well, how many is it going to take before we rupture your glute med here?
Well, yeah, funny you say that, because this example is actually a glute med rupture. It's a gentleman that came to me for PRP for a high-grade quadriceps tendon tear, like really high-grade, like surgical. He went to see the surgeon. The surgeon said, you know, you're doing a lot better than I would have expected. Let's not do surgery. Let's do PRP. We did PRP twice. He came to see me for a third PRP. And he said, you know, I felt something pop in my butt. And I went, oh, no. So I scanned him, and while he was doing his rehab for his patellar tendon, or for his quad tendon, he somehow, his glued med tendon let go. So he said, will the PRP help? I say, look, I don't know, but we're doing your quad tendon anyway. Why don't we take some extra and we'll pop some in? And he gratefully, thankfully allowed me to record it so then I can share it with you so you can see what it should look like when somebody has a high grade tear. So I'll just show that one more time. So in this view here, there's a little white air bubble there, and there's an absence of tissue. Now, obviously, this isn't the best diagnostic picture I could possibly get, but that's what it looks like when we do these injections. All right, moving on to, we'll skip past SI joint and let's get to knee joint. Knee joint's the one we do most commonly. I always go suprapatellar recess. Unless I don't. So, Mike, when you've got somebody who's had some injuries or some fibrosis in the suprapatellar recess and you just can't get a good spot, my go-to is to go to, this is the medial side of the knee, and I'm going from medial to lateral, and I'm landing immediately underneath the patella. Do you have a go-to? Like, do you continue to use the ultrasound if you're not going to go suprapatellar recess, or do you just go blind from the front?
You know, I would say 99% of the time, I'm still doing that suprapatellar recess from the lateral aspect. And I just do a little lidocaine, superficial down to the capsule through that lateral retinaculum. And then that's one time, if it's a totally dry knee, I try to find that space. I'm constantly I usually have like a bolster under the knee, and I'm having the patient actively move their knee. And you just see the tissue planes kind of move on each other. That gives me an idea where the knee joint's at, and I try to drop a little bit of lidocaine in there. And once I see just a little bit of lidocaine go into that joint, say, great, I know that's my spot, and with confidence I can enter with my PRP.
Excellent. And in the case where you don't want to use too much lidocaine, you can simply use a normal saline. And actually, you could even have like a touch more PRP and just do tiny little puffs of PRP and avoid the lidocaine altogether. So there was, again in the video. Now, if you're interested in learning more about some regenerative medicine stuff, I'm on the board of directors of a group called the AAOM, the American Academy of Orthopedic Medicine. At our conference last year in Pensacola, Florida, where Transcend Biologics was present, we had a great talk from a guy named Joe Albano. Joe practices in Utah, and he gave an interesting talk about how he treats meniscus tears and knee injuries with regenerative medicine. So just a little shout out if you're interested in learning more about regenerative medicine. AAOM is a great go-to. There's a question from Ainsworth Farrell that says, how much do patients need to pay for PRP procedures, shoulder? What's it like in your clinic now, Mike? What does somebody do? Let's say rotator cuff.
Well, I'll maybe go back. When I first moved down to Texas, I worked in an academic center, and so I have no say in pricing with that. But I helped kind of guide them, and what we did is we did a market analysis. We just looked and said, okay, in East Texas, who's doing PRP and what systems are they using and what are they charging? And that gave us a general ballpark. Then I provided basically those numbers and figures to administration, and they came up with a figure. They just charged per kit regardless of location.
Okay. And
here in East Texas, it was generally speaking, probably $650 to $800 was average.
Okay. Now, there's going to be some places charging $2,000, and there's other places charging $400. I guess the one thing I would say is, if you're new to this, I think it's probably a little bit cheeky or presumptuous to charge $2,000 when you're new to it and you're still learning the pros and cons and the ins and outs and learning through fire. So yeah, I think you just got to figure something out. In my clinic here in Calgary, we charge about $800. And so chatting with other people, I think that's a reasonable, but again, the way you did it is great. Just do a market analysis, right? Let's move on to, Now, I'll include this one in the top 10 because Mike knows this gentleman. So this is patellar tendon. This scar is from something completely different. However, here is an example of this is short axis on the patellar tendon, and this is normal healthy tissue. And this is an intrasubstance abnormality where there's clearly defective tissue there. And so with a PRP, we really want to get the needle in the stuff that looks defective, but also the healthy tissue adjacent it. And this gentleman, you see his face there. This is about the best you can possibly tolerate patellar tendon PRP.
Yeah, that's not fun. That is not a fun procedure. Much better to give than receive.
Yeah, absolutely. Ankle joint, we just I did a webinar on Monday with a podiatrist from the Mayo Clinic, and I said, I treat a lot of lateral ankle sprains with PRP. I don't do many ankle joints. And she said, well, that's interesting because in my practice, I do a ton of ankle joints and not much lateral ankle. Now, Mike, you come from a sort of prolo world where we treat a lot of chronic ankle sprains and lateral ankle pain, post-ankle sprains with dextrose and PRP. What are your top tips about patient selection for how do you know when to treat the ankle joint, and how do you know when to treat the ligaments on the lateral side or medial side?
Boy, man, that's tough. That's I think $1 million question. So I think I look for tips to me to think, okay, is this really an intra-articular pathology? Is that their main pain generator versus are they having more true focal extra-articular ligament laxity? And a lot of that is their history and their exam. And as part of that, my palpation. Traditionally, I've had more experience using prolotherapy targeting like the ATFL, CFL, AITFL, deltoids, more probably just because of the price point. And then I have used PRP for lateral ligaments, but I probably use PRP more intra-articular and prolo extra-articular.
And here in the course is an example of me treating. For this person, I treated this was a patient who had an inversion sprain, distal fibula avulsion fracture, an osteochondral defect in the talus. A year and a half, 2 years go by, and there's still lots of pain in there. Multifocal pain medially, laterally, proximally at the high ankle, distally into sort of sinus tarsi. And when you've got these broad areas, like you say, based on physical exam and patient report, I think like nothing helps sort it out more than an intra-articular low-dose cortisone injection. And if all their pain goes away for 6 months, maybe that's all you got to do. So that's what we did in this case. We did low-dose intra-articular cortisone. Pain went away for 2 or 3 months. And then when the pain came back, there was fewer pain points. So then it was able to narrow it down and treat all these spots with PRP. And in this case, I think I had maybe 6 or 9 mils total. We treated all the way around.
Wow, that's impressive.
Here's an example of the ATFL PRP. So here is the distal fibula. Here is the talus. And we're coming up on time, so we'll finish this up and then answer any final questions if there's any final questions. And there's the ligament, and the needle really goes right into the middle of it, just like the patellar tendon, just like the supraspinatus tendon, and just little puffs with my thumb. You can see gentle little puffs there. Excellent. So plantar fascia, I don't actually have a video of this. As many as PRPs of the plantar fascia I've done, this is one I didn't have a video of. So I included a video of me doing a hyaluronic acid. The way it goes for the hyaluronic acid. So again, there are lots and lots and lots of places around the world where you can get a low dose, low molecular weight plantar hyaluronic acid that's appropriate for soft tissues. And Canada is one of them where I live. And so this is an example of me injecting a little bit of hyaluronic acid superficial to the plantar fascia. But for PRP, you would, again, just literally pepper a little bit into the tendon, into the fascia itself. When you do these, Mike, do you put people in a boot afterwards, or is it patient dependent?
I do. With Achilles and plantar fascia, I tend to put most of them in a boot. It is patient dependent, but I just feel better immobilizing them in a boot usually for a week.
Okay. Well, I hope that was helpful. I want to remind you that this is available. There's a free PRP course on our website, sportsmedus.com, sportsmedus.com/free. And you look down here for the Learn PRP free version. It's about a 1-hour course with video content, me walking through different things. And just a reminder that February 8th, 9th in Dallas, we're running a course where the first day is ultrasound scanning and top 10 PRP protocols. We help you scan, make sure you got the patient in the right position, the machine in the right position, your needle approach angle correct. And then day 2, we're going to get past all those barriers we've learned about in this past 57 courses we've done, where people say, like, I'm interested in PRP, but man, not this year. We help you learn how to do a blood draw, an accurate best practice blood draw using ultrasound, how to do get the kit perfectly prepped. And again, the kits we're going to use are the Transcend Tropocells kit, the best practice mock patient encounter, because you need to see how I talk with a patient about, honestly about what they can expect with PRP for results and post-procedure. And then again, there's going to be sort of a quick practical exam to make sure you look everything you learned in day 1, you can still remember on day 2. And so that's going to be our course. The price is $12.95 US. And Craig, if you can hop on the call quickly here, because I think Transcend's got a deal for you. It's something about the amount you spend on the course can be discounted towards purchase of a WeSonic ultrasound machine. Is that right, Craig?
Yeah, that's right. So for anybody that attends the course, whatever you pay for the course, that will be your discount toward an ultrasound machine that is going to be there. And also, just in the chat, everybody, we love these webinars, and we greatly appreciate Dr. Johnson and Dr. Galbraith today to come and help and lead this. It was an outstanding course. We are always looking to make it better. And so if you have time to take our little survey that's in the chat, you have up to January 22nd to do it. I think we may even send this out to all the participants that were on the call again today. So, yeah, looking forward to it. I think the course is filling up in Dallas. I'd love to have more people as well.
Excellent. Well, Mike, thanks for taking time out of your busy practice schedule. For everybody who attended, thanks very much for attending. And enjoy the rest of your evening, and hope to see you in Dallas or somewhere else in 2025. Bye for now.
Thanks, everybody.
Thanks, guys, for having me. Sure appreciate it. Yeah, Frank and the gang, and yeah, Craig, I appreciate it. Good to see you had some good turnout, and hopefully some good turnout in Dallas too.
That'd be great. Yeah. Thanks for your time. I appreciate it.
Take care.